In this session, we'll be covering the treatment of patients under a workers' compensation framework, and we'll cover some of the challenges in managing injured workers and how the funding model and workplace environment can impact outcomes. We'll also discuss virtual care and how it is applicable to workers' compensation cases. To lead this session, I'd like to introduce our moderator for this session, Mr. Nick Ward. Nick is the former head of Medibank's Population Health Delivery Network with 24 years of experience in the health and wellness sector. He's Telecare's clinical operations manager, overseeing the administration and facilitation teams on a day-to-day basis. I'd also like to introduce Dr. Jason Chen, a close friend and colleague of mine. Jason is a rehabilitation physician and holds a public hospital appointment at Western Health in Victoria. He specialises in the rehabilitation of chronic disabling medical conditions such as stroke, multiple sclerosis, cerebral palsy, spinal cord injury, acquired and traumatic brain injuries, and musculoskeletal disorders, as well as pain management and cardiac rehabilitation. Jason has a special interest in neurological rehabilitation and is skilled in the injection of botulinum toxin to relieve spasticity. He also holds a diploma in pain management, with his main interest being neuropathic and musculoskeletal pain conditions and pain in older persons. He has a passion for holistic care and the restoration of maximum independence and quality of life through rehabilitation. So I'll pass on to Nick to lead the session. Thanks so much, Nick.
Brilliant. Thanks so much, Ray. Welcome, everyone. Yeah, we're here to talk about workers' compensation and yeah, your role as nominated treating doctors in that process. So just to kick off the discussion today, I thought that what we do is just look at some of the types of challenges that no doubt you've seen as treating doctors when treating workers' comp cases. So what we know is that injured workers they're highly vulnerable when they cannot go to work. There's still too many employers that fail to engage their injured workforce, and it really creates this effect of where it detaches the employee from work, and it really undermines their social supports as well. A workplace injury creates a lot of doubt for workers or for a worker, especially in the instance when their career or financial prospects are threatened, as can be the case. And then some workplace cultures, they still continue to stigmatize in the injured worker. You know, they perpetrate the myth that people on compensation are bludgers, where studies have been shown that less than 3% of the entire workers' comp population actually consciously malinger and exaggerate their symptoms to, you know, benefit from the process. Psychosocial factors, they also play a huge part in a worker's recovery. There is an approach that's needed with workers' comp where you need to really look at the whole person and not just the actual injury at hand, knowing that, you know, the longer that a worker stays off work, the less their chances of having an effective recovery. There's also the liability process as well, which is involved in workers' comp. You know, there's that, you know, when a claim gets accepted, it will generally only cover the component that's work-related, and yet there might be, you know, other, you know, contributing factors to that injury which also need to be treated as part of it. So it's sort of navigating those liability issues. We'll talk today about, you know, red and yellow flags. So red flags being, you know, physical indicators like comorbidities, yellow flags, which are your psychosocial factors like, you know, I mentioned before, you know, lack of social support or undermined social support structures or problems in the workplace due to the claim. Those non-work related factors are often just pushed to the side and not addressed when dealing with workers' comp claims. But, you know, many studies that have been done show that, you know, treating the psychosocial factors when it comes to managing an injury is almost as critically as important as managing the actual injury itself. The other thing is that most workers' comp claims are actually quite traumatic in nature. You know, they're generally about 90% of them are, you know, traumatic injuries, that leads to pain, and it can lead to chronic pain if not treated from the outset. Now, that's they're the challenges. I'm not sitting here for a second suggesting that all workers' comp claims are complex like that. A lot of them are just open and shut cases that are treated very, very much as you would treat anything else in general practice. But what I'd sort of, when I'm mentioning these challenges here today, I'd ask you all to think about your own experiences in workers' comp cases and the types of issues that you may have seen in your own practice, to think about some of them as we talk. So really, my first question today is to you, Ray. So now you're a GP and you've seen your fair share of workers' comp cases. Do these sound like familiar challenges to you when you're treating an injured worker?
Sorry, I just realized I was on mute. So absolutely, yes, these are very familiar challenges. And I would say that in particular, with regards to an unsupportive workplace as well as yellow flags, those are probably the two key factors that I've seen as challenges that really inhibit a worker's recovery. And when those things are dealt with, where there's a supportive workplace and culture, a real support network outside of work as well, with supportive partners and no other kind of psychosocial stresses, that's when I've seen workers return quite successfully back to work. They're keen to get back, they're back there kind of within a week, whether it's just in an altered role. And they are the patients who have better outcomes when there is the lack of those yellow flags, as well as a very supportive workplace. So that's my experience, certainly.
So Ray, do you have any sort of real life examples of where you've had to deal with tricky cases and some of the things you've seen and experienced in workers' comp?
Yeah, so I think the two tricky cases that come to mind are, so I guess I saw a warehouse manager in his 40s, actually, when I was quite junior in my career, who had injured his back whilst offloading a pallet of heavy goods, and they were short-staffed. They were under pressure from the boss to get it done. So he probably did something that he probably shouldn't have, knowing being a warehouse manager, he knew exactly what not to do, I suppose. There was an initial good kind of reasonable recovery with a return to work, and then a subsequent re-injury. Now, I guess the problems were that the workplace weren't particularly supportive of alternative duties. So even though this worker was really well qualified to do other kind of back office roles with some skills in kind of logistics, they really essentially gave him alternative duties that were, you could consider, demeaning and not really utilizing his skills. And then ultimately, he was eventually made redundant while still on a WorkCover claim. And this really then degenerated into kind of secondary depression, and there was kind of quite a bit of injustice, a sense of injustice that was conveyed by the worker, which really prevented recovery, I felt, with some other, you could say, red flags in terms of other kind of pre-existing alcohol issues, which were definitely exacerbated by the work injury. So that was one case. And what I learned from that was that really, as a GP, it was really important for advocacy on the patient's behalf to the workplace to really get them kind of good alternative duties that were fitting for the worker, because they were available. It was just that the workplace wasn't supportive. And unfortunately, at that stage in my career, I was a registrar, so I was rotating. And in that critical period, I had gone to another practice. And so the patient didn't really have anyone to advocate for them in that critical period. And then another case that I can think of was a cleaner in her 50s who was injured whilst doing an extra clean, actually, ironically, for an executive walk around the next day at the private hospital that she was working at. And she initially didn't want to claim work cover. She was a hard worker. No, I'll just kind of treat it under Medicare. And it was really unfortunate that as she started to talk to her work about covering some of the medical costs, she was also made redundant subsequently by the hospital. And although we really tried early referrals and intensive rehab, I think that there was certainly a major barrier was the injustice of the whole situation, and that she had tried everything that she could. Despite that, an unsupportive workplace really prevented her recovery. In some ways, her recovery might have even been worse off without the support of telehealth during COVID. Certainly the isolation from COVID during the pandemic made things a bit worse for her as well. So those are kind of two cases, but I have plenty of other cases to discuss if need be.
Brilliant. Thanks so much, Ray. And Jason, you know, you're a rehab physician. You know, you see a lot of these types of cases where there's, you know, multiple compounding issues. You know, I'd be keen to sort of hear your thoughts on some of these challenges and how you've dealt with them and what you've seen as well.
Yeah, sure, Nick. Yeah, I'm happy to share some of my experiences. So treating workers' compensation patients in my practice as a rehabilitation physician and in pain management. Firstly, I'd like to thank Telecare for asking me to be part of this panel and the audience for attending the session. So I mainly work in a hospital setting. So I see patients with a wide range of workplace injuries, generally more significant injuries that require hospitalization, such as head injuries, spinal cord injuries, orthopedic fractures, spinal fractures, limb amputation. And most of these patients require a subsequent inpatient rehabilitation or an outpatient rehabilitation treatment. And I think it's important to reflect on what makes a case complex and what makes it straightforward, as I'm sure GPs have encountered similar experiences. As an example, I treated a 31-year-old male who was a window cleaner. He fell from a height and sustained spinal fractures that required surgery to fix the fractures. And post-operatively, the pain improved, his wound healed well. He underwent a short sort of outpatient rehab program and subsequently returned to work on light duties, working in a desk job. So he sort of did quite well. It's fairly straightforward in the recovery process. In contrast, I also treated a 45-year-old female who was a factory worker who slipped while walking downstairs, fractured her ankle. She also underwent surgery. Unfortunately, there were sort of complications with screw loosening, and she required a further surgery a couple of weeks down the track. She subsequently developed complex regional pain syndrome in the foot. And sort of delving into her social history, she sort of reported some tension in her sort of marriage after the accident. She also had a history of anxiety and PTSD from a previous motor vehicle accident, which with the symptoms worsening sort of now, sort of insomnia. She also had a young family, sort of 3 young kids. So with her, she still have not returned back to work now, so 1.5 years down the track. She's also sort of have lodged a case to WorkCover for compensation as well. So as you can see, sort of very different trajectories and sort of some learning points that I'd like to share is that for both patients, I have early discussions about return to work goals. And I think it's important, as Nick had mentioned, the longer a worker is off work, the harder it is to get them back to work. And workers' compensation is a difficult system to navigate for patients. So especially those who are non-English speaking, who have low literacy, who have limited social supports. And the funding is somewhat designed for the biomedical and rehabilitation model, where there's an injury that can be treated, resulting in physical disability that can be overcome with rehabilitation. So those orthopedic fractures, needing surgery, then subsequent rehabilitation, and then a graded return to work plan. So it works very well for those patients. And the process also depends, as you all would know, how accommodating the employer is, whether the worker can do modified duties within their capacity. And so a good occupational rehab provider is invaluable in liaising with the employer. But it's those patients who have comorbidities such as significant depression, anxiety, who's distressed, who's angry, who is finding it difficult to adjust to their injury, who have unstable social networks. I find that for these patients, it is trickier, and there's a tendency for patients to have to prove that they have a disability, and that is the reason why they have difficulty returning to work, rather than a focus on rehabilitation to overcome the injury or disability. And with these patients, it is hard to separate what is work injury, what is pre-existing, and often you'll need to involve specialists for like an independent medical examination to delineate what is the work injury. And another point that I want to emphasize is when treating doctors complete a work capacity certificate, often if you certify that a person is not fit to work, and even though they may have some capacity to do modified duties, then it leaves very little room for the rehab providers to help the patient in their process to get back to work. So rather than thinking what their work duties are, I would focus on what their current capacity to do duties are like. Yeah, rather than we just think that they can't do the previous duties. So those are some of my experiences in looking after workers' compensation patients.
Brilliant. Thanks so much, Jason. We're certainly seeing, the challenges that we talked about earlier on really shining through, just re-emphasizing the importance of the role that an employer plays when a worker is injured at work, and their attitudes towards that injury and towards the rehab process. We talked about modified and suitable duties. There's 8 major or 9 major legislations in workers' comp in Australia, which is again tricky because it just means that there's different jurisdictions to have to navigate. But most of those jurisdictions mandate the requirement for an employer to provide suitable duties of some form. And so when you're in that role as a nominated treating doctor, when you're writing a medical certificate that says that you're unfit, is really saying that person can't do anything. They're generally completely bedbound and unable to go and sit at work or do very, very light duties. So it's just a really important consideration as a treating doctor to consider and bear in mind that employers are required to provide suitable duties under workers' comp law. As well, we talked about navigation of the system. It can be very complex for an injured worker, knowing what they're entitled to and what they're not. That is why I think we talked about that early referral to a rehab provider if there is significant return to work issues, to get that provider to actually get involved as part of the care team and to help the worker to navigate the process and to negotiate with the employer. So really, the advice is to really utilize occupational rehab providers wherever necessary to help with that process. Ray, before you were giving one of your examples before, I'd sort of written down a bit of a case study that's actually very similar to the example of the store person that you were talking about. So I might just sort of read it out and just to give some food for thought, because this is a real life case study that I had experienced, literally hundreds of these types of injuries. So let's consider we've got an injured worker. They present with a low back injury. It's most likely that as your own patient, they've come to you as their GP because it's their choice as to who they go to see, and you would be the first real point of care for an injured worker. This patient that we have in mind for this case study, they're in their mid-40s, they're moderately obese, they have issues with hypertension, also diabetic. This person has struggled for a number of years with pain, including low back pain, which they've just aggravated at work. And in recent years, this worker has suffered from depression and become anxious about job security issues, which has in turn placed strain on his relationship with his spouse. At work, and despite voicing concerns over unsafe manual handling practices, his supervisor insisted that he move numerous heavy crates by hand without assistance because a work order needed to be urgently prepared. And now as the day wore on, he felt a locking sensation and a sharp pain in his low back, referring down into his right leg. Around mid-afternoon, he advised his supervisor that he could barely move. So on the way out to attend his GP, he overheard his supervisor making negative comments about people who wanted to get back onto the compo train and not work. So that's the sort of case study that we presented there today. Ray, you had highlighted something very similar as a real life example as well. And it does sound like a nightmare case, but these are the realities of working with workers' comp cases. So Ray, what type of approaches have you learnt to take, in situations like that we haven't covered, if we haven't covered them, and what about, have you had times, both of you, as doctors who've treated workers' comp patients, where you've actually we've made mistakes and you've had to learn from those mistakes and realise that the next time round, you would handle something like that differently?
Thanks, Nick. Yes, so it is a very similar case, and I think it is actually speaking to the fact that actually lower back pain is a very frequent occurrence in workers' injury cases. So I guess certainly through the past years, particularly early in my career, not understanding the importance of getting people back to work. One classic mistake is writing not fit for work. I think that's certainly a real big mistake that I learned pretty early on, is to make sure that they're noted down for our modified duties or alternative duties, not completely incapable of work. Second thing is making sure to refer early. Sometimes it's more reassurance for the patient that they are okay to work, that they don't have any major injuries, and that things will get better. And sometimes, unfortunately, patients do need that reassurance that they have had everything done for them and everything assessed properly. Referring to a rehab provider or kind of physiotherapy support, I think was one of the learnings that I had from a case where I potentially didn't refer them early on enough, and the outcomes were not as ideal. And so I think and then in conjunction with that, as I kind of mentioned before, advocating for the patient to the employer so that the employer feels that, you know, the patient is ready and willing to work. It's just that they need some alternative suitable duties. I think that was another lesson that I've learned in the past from these nightmare scenarios. And when done properly, I have seen patients go back to work. They may still kind of have an ongoing open WorkCover claim to help cover costs of, say, a physiotherapist, but they're doing productive work in an alternative role well into the future. So I think these nightmare scenarios can get better. Patients will need a bit of encouragement sometimes. And I guess the other thing that I thought I might add, it's more of a personal example. My cousin actually, you know, probably about 10, 15 years ago now, was working at a bar for a large corporation. He sliced his hand open. Then because it was a large corporation, they had proper kind of return to work processes. They got him a job in the marketing department, which he had an interest in. And, you know, subsequently he became the director of international operations after about a decade or a decade and a half. So, you know, there are actually, when one door closes, another opens, as they say. So, you know, getting workers back to work in an alternative role can actually be life-changing.
Brilliant. Thanks so much. The next question I'm going to ask will be to Dr. Chen. Just in relation to, I just want to shift the discussion, conscious of time and allowing time for Q&A as well. But I wanted to shift the discussion towards telehealth. This is a digital health focused conference after all. And just using telehealth as a care pathway for workers' comp cases. Now, Jason, you know, you are one of our specialists who provide telehealth services on behalf of Telecare. You know, what do you see as some of the advantages and disadvantages of telehealth for workers' comp? And have you got any advice? And this is a question to both Jason and Ray. But have you got advice to our audience on what types of referrals are really appropriate for telehealth for workers' comp?
Yeah, thanks, Nick. Yeah, I think so I work doing telehealth, seeing patients for pain management. And yeah, this is a not uncommon patient presentation that's referred to me. And I think it was interesting to hear Ray's experience as the first, often the first doctor that patients see when they have an injury. And I can attest to the challenges and the learnings over time when we see and treat patients with a workplace injury. In regards to, I think that holistic approach is important, especially patients who have the complex yellow flags that may have an impact on their return to work outcome and their journey. And identifying yellow flags as part of and the initial assessment is crucial in coming up with a plan that ultimately will lead to a better outcome. And with telehealth now, it is easier to access specialists for patients who live in rural towns where it may be difficult to access specialist care. And I think with an example for this patient with back pain, I think having the right approach from the beginning and the right education to the patient makes a big difference. And it is, like I said before, it's challenging to separate what are the psychosocial factors in this patient causing their persistent back pain versus whether there is ongoing nociception sort of causing the pain, and the approach is very different. Most of my patients I see in clinic have a large component of anxiety, distress, fear, catastrophization that's sort of driving their symptoms. And for GP, it is very difficult with sort of the time that sort of we are all very busy, and I think sort of 15 to 20 minute consultation, it is very hard to provide that education for patients, and through sort of linking to a sort of clinicians who have experience in pain management, where sort of that consistent message and education is provided to patients early on, can really help them sort of to manage their pain, and improve their self-efficacy, and sort of improve their function, rather than sort of the pain cure that sometimes patients are seeking. And I think having clinicians, sort of physiotherapists or psychologists who have experience in managing patients with chronic pain is important, sort of does make a difference. Sometimes patients, when I suggest that I want to refer them to a psychologist, they would say that they've seen them before and they don't find any value. But I often say sort of we at Telecare, we do have sort of psychologists and clinicians who have experience in working with patients to help them manage their pain, and it does make a difference in terms of the education that's provided. And yeah, I think sort of another sort of point is that it only sort of takes sort of one clinician to say to the patient that sort of we can sort of fix the back pain using sort of massage therapy, injection, ultrasound, for it to become a very difficult issue to manage. And I think sort of it's important to build that self-management, self-efficacy for the patient. And I think with Telecare, it's handy sort of accessing the clinicians who have experience in these areas, bridging the gap and improve access to regional towns. One limitation is the physical examination that sort of we're unable to do via telehealth, and sort of through sort of working with seeing patients via telehealth, I really appreciate when GPs in their referral sort of document an physical examination, and also sort of really appreciate their time when they sort of sit in at the end of the consultation when we discuss management plan with the patient. So I think sort of that sort of does help sort of with that coordinated care that plays a vital role in managing these patients. One of the sort of challenges that I see is that sort of patients may see a physiotherapist here, a psychologist there, a doctor here, sort of another sort of specialist there, and then sort of they got sort of conflicting information, and it's very confusing for the patient, let alone sort of like the doctor looking after the patient with such a complex sort of issue. So sort of I sort of it's been sort of, I think COVID has sort of provided me with the experience in treating patients via telehealth, and sort of I find that it does work, and sort of I'm gaining more experience in this area, whereas prior to COVID we see patients in clinic, at the hospital setting. And yeah, I think sort of that's my experience.
Brilliant. Thanks, Jason. We are sort of getting towards the end of the session, and I did want to give some time for Q&A. Just Ray, really quickly, when you're a GP and you're referring to telehealth, or for a telehealth consultation, what are you sort of looking for as factors in a case that would, be appropriate for that type of referral to be made to a specialist via telehealth?
So I think often mental health is probably the number one telehealth appropriate referral. And it really depends on where the patient is located, of course, and their logistics concerns as well. Because if they can access a face-to-face consult with, say, an orthopedic surgeon for a fracture, then that would be ideal rather than via telehealth. So a lot of mental health associated referrals, I would say. And then I guess in terms of facilitated consults where possible for the rural GPs, that might be an option, as Jason was alluding to. Physical examination, really you can't get over that limitation through telehealth without, say, another provider being there to assist and help and pass on the information. I guess something from the kind of general gist of things, it sounds like case conferencing is really important because getting everyone on the same page, I think it's not just even workers' compensation. There's other problems like eating disorder patients where case conferencing really has been very helpful at getting everyone on the same page and not kind of, I suppose, having different plans and getting the patient confused. I think that's really important. So that's my take on telehealth appropriate patients, and I guess a sidetrack into kind of case conferencing, which can help immensely in planning for a patient's treatment plan for going forwards.
Thanks, Ray. Yeah, and it is important to point out that there are, funding models that they're all different depending on which state or territory or jurisdiction you're operating in. But there is funding within workers' comp environments for case conferencing for both specialists and GPs, which is available. And I think workers' comp does lend itself largely to case conferencing. A lot of it is done, in that manner, particularly with the rehab providers talking to GPs and other specialists and other members of the care team as well. So yeah, look, I think we'll give some time now for any Q&A that people have. We've been getting chats coming through, which we've been trying to address as we've been going on. So yeah, just some time for any questions that our audience may have.
I guess, Jason, looking through the chat, there might be a question for you. I mean, I would like your input as a specialist in rehab. Reducing. So Musin has asked, reducing lost time is a hard one when it involves the mental health issues as part of work injury. Your take on how to get around that, or I guess kind of move through that block to patient's recovery.
Yeah, I think it is. Some limitations are difficult to overcome, and I think starting the discussion early and sort of, I think showing that you're sort of listening to the patient's concerns right from the start, and that you're sort of reinforcing the benefits of that return to work and being at work, and then sort of identifying the barriers early, and then sort of addressing those barriers appropriately. And I think lost time, I think I haven't had a lot of sort of experience in terms of tracking sort of how long they've been sort of off work. Often I think sort of GPs, when you do medical certificates, you tend to have a better idea of sort of the time frames, and sort of I see them at various sort of points in their journey as well. But I think sort of just to emphasize that sort of that early assessment, sort of that coordinated approach early on, addressing the patient's concerns, and setting goals together with the patient. Because a lot of patients do want to get back to work, and sort of helping them with the process. And there will be those tricky patients where even with specialist input, it's not easy to get them back to work. But I think having the that coordinated approach early on does make it easier for GPs, and sometimes having, like Ray have said, for patients to see another doctor just to provide that reassurance that they're getting the right treatment. Because most of the time GPs do provide the right treatment for the particular patient, but sometimes, for certain patients, they may need a second opinion. So that's my experience. Yeah.
What I'd like to add to that, and thanks so much, Jason, for that. Just addressing that question, mental health, it is, a significant issue, and it can become, an absolute showstopper, when it comes to a workers' comp claim. Just as GPs, when you are, creating a return to work plan or looking at modified or suitable duties when it comes to mental health issues, or if the mental health injury is the prime injury. A lot of mental health injuries in workplaces are actually caused by tension in workplaces. It might be poor working relationships with managers. It could be a whole raft of things. But when a workers' comp claim has been accepted for those mental health injuries, it's just important to consider what those workplace stresses are in the first place. So suitable duties for a mental health claim could look like, it might be, look, this worker can't work in the same department that they're currently working in because they've got conflict with, a number of individuals or a particular individual which has caused their injury. So it's thinking more, broadly, and it's like, the same way that you would look at writing modified duties for a physical injury, but trying to, remove the patient, from the stresses that have caused that psychological injury in the first place.
And my experience is also asking just having a good conversation with the patient about what return to work that's safe for the mental health looks like, I guess. There was a question about trying to find psychiatrists or psychologists for an early appointment, which is always a challenge, and I think that's where telehealth referrals do sometimes offer a broader pool of psychologists or psychiatrists. And although video doesn't work well for everyone, there's certainly a subset of patients where video does work well, but you have to pick your patient carefully, because there are some patients that really do need that face-to-face rapport building that won't respond quite as well to video service.
Yeah, I think it comes back to that question, Ray, of if what are you better to have care that's delayed by 6 months in order for someone to see face to face, or to actually proceed quicker and get access to, say, a psychiatrist via video, and not let a significant period of time pass before that care journey begins. So I think it is definitely weighing up these prospects. But as you say, Ray, you're seeking to have a conversation with your patients, just in relation to what's going to work for them, and certainly putting out there that there is the option for a video or telehealth consult. The injured worker may be really amenable to that, because they're like, well, I can see a psychiatrist in the next 2 weeks. I don't want to wait 3 months. Okay, well, I think we're sort of starting to run out of time for this session. Did we have any other questions that haven't been addressed in the chats here? I'm just looking through to see if we have. I think we've covered most things.
There was a question about accessing super. I must say I don't know enough about the criteria for accessing superannuation. In general, I would say I have rarely ever recommended that. I have seen one patient use it who was not my patient. So by the time that had come to me, they had already accessed their super after a workplace injury and after that WorkCover process had run out. And they were on a DSP and then accessed their super. That is a very complex patient, which I probably still trying to sort through their care.
There are some aspects of super that you can access. It just depends on the policy that you might have with your employer as well, like the kind of insurance cover. But there is a type of insurance called top-up insurance, where if there's a significant discrepancy between the workers' comp weekly benefit and their pre-injury wages, they can have that amount topped up, but it doesn't come out of their super. It's part of their insurance that comes with their super, like part of their total and permanent disability, that type of cover. So, yeah.
I've also seen, very rarely that patients access super, other than sort of those patients in hospital with like a catastrophic brain injury who are sort of permanently and totally disabled. So those are the patients who I've helped access super, but sort of majority of patients where sort of there's the return to work goal, sort of, we don't think sort of there's benefits in super for those patients to access. Is sort of my experience.
Yeah, there are sort of every workers' comp scheme has, permanent impairment and pain and suffering, payouts that can be achieved, but you've got to go through the rehab process first, and it will usually take a couple of years. So, to sort of get to that state where you'll assess a whole person impairment and the worker will get a payout. So those types of payments, tend to alleviate the need for an injured worker who's, seriously disabled or, permanently impaired, to cover that without them having to touch their super. Now, I am looking at the time. Dr. Ray has to, he's in his scrubs there, and he needs to take off and go and provide vaccinations. So, so yeah, I might take this opportunity to wrap it up here, because I know, Jason, you need to get across to the other side of town as well and continue your day of providing care too. So, thank you so much, both of you, for attending this panel discussion today and sharing your thoughts around workers' comp. Much appreciated.